Hello, I am Jolie Long with the National Board for Certified Counselors. On behalf of the Medicare Mental Health Workforce Coalition, we would like to welcome you to our webinar today. Next. Before we begin, I would like to share some meeting details. Closed captions are now enabled, and attendees can turn these on and off as desired. Interpreters can join the meeting via the phone number, ID, and passcode provided on this slide. A link to this PowerPoint presentation will be posted in the chat so you can access the links on this slide. To receive continuing education credit, you must complete the session evaluation, including the attendance attestation. The link to the evaluation will be posted in the chat at the conclusion of this webinar. We will also send you an email with a link to the evaluation following the webinar. We will only be providing continuing education credit for live attendance. This webinar will be recorded and made available on the NBCC website and other coalition member websites for viewing purposes only. Due to the large number of attendees, the participants will remain in listen-only mode throughout the meeting. The presenters will be taking questions at the end of the session, so please feel free to type your questions into the Q&A box at any time. Next. This is the 17th Medicare webinar that the Medicare Mental Health Workforce Coalition has produced. Please find information on videos of the previous presentations via the link on this slide. Next. The Medicare Mental Health Workforce Coalition consists of organizations that collectively represent providers, clients, patients, and other stakeholders. Our overall mission is to increase access to client choice for mental health provider care. Together, we achieve this goal with the passage of the Mental Health Access Improvement Act. The coalition is now working to ensure successful integration of counselors and marriage and family therapists into the Medicare program and providing clinical education resources to work with Medicare clients. The coalition members are listed on this slide. Please note, we also recently welcomed the National Association of Social Workers as a new coalition member, so welcome to social workers that are in the webinar as well. Next. Today's webinar is titled Substance Misuse in Older Adults, Trends, Challenges, and Solutions for Improved Care. The learning objectives are listed on this slide. We welcome Dr. Fred Blow, Professor of Psychiatry at the University of Michigan Medical School. He will be followed by a marriage and family therapist and a mental health counselor who will share their reactions to Dr. Blow's presentation and talk about MFTs and counselors training and their work in the field on this topic. I would now like to introduce our speakers, and their full bios are in the slides for your convenience. Next. Dr. Fred Blow is a professor of psychiatry at the University of Michigan Medical School, where he holds the Rachel Upjohn Research Professorship and director of its Addiction Center. He also works as part of the scientific leadership team at the E4 Center of Excellence for Behavioral Health Disparities in Aging at Rush University Medical Center. Dr. Blow serves as the inaugural National Huss Hazelden Endowed Research Chair on Substance Abuse in Older Adults at the Butler Center for Research, Hazelden Foundation in Center City, Minnesota, and as a prolific scholar with over 400 publications, articles, chapters, and books. Dr. Blow is a nationally recognized expert in mental health and substance abuse services, research, and policy. His work spans lifespan-focused prevention, alcohol screening and diagnosis in older adults, co-occurring mental health and substance use disorders, brief interventions in healthcare settings, suicide risk factors, and implementation of evidence-based practices. Next. Dr. William Northey is a licensed marriage and family therapist in Bellefonte, Delaware, with almost 40 years of clinical experience working with children and families. He received both his master's and doctoral degrees in marriage and family therapy and is a leading expert on strategic family therapy. As a clinical director of the Belfonte Center for Children and Families, Dr. Northey is dedicated to helping families that get stuck, whether that is because of issues navigating developmental stages and transitions like adolescence or divorce, or dealing with the impact of substance misuse and other compulsive behaviors have on families. As the CEO of Q3 Analytics and Consulting, he provides staff and program development, program evaluation, and enhancement consultation, and has written over 60 RFP responses, securing over 50 million in grants and contracts. Next. Dr. Phillip Clarke is an associate teaching professor in the Department of Counseling at Wake Forest University, where he has been a faculty member for 12 years. Dr. Clarke has been a licensed clinical mental health counselor since 2006 and has worked in addiction treatment settings and a hospital-based program that provided counseling for individuals diagnosed with neurocognitive disorders and their families. He has co-developed and researched a wellness coaching program for older adults and conducted scholarship on counseling and support groups for family caregivers of individuals with neurocognitive disorders. Next, I would now like to welcome Dr. Blow to begin his presentation.
Thank you so much, Jolie. I'm really excited to be here today, and I hope we can cover a broad range of topics. But I wanted to first just say that I have disclosures to tell you about, which is mainly research funding from the NIH and other agencies. I'm also, as Jolie said, the Huss Hazelden Betty Ford Foundation National Research Chair on Older Adult Research and the co-scientific director of the SAMHSA E4 Center at Rush University, and I receive compensation for those roles. Otherwise, I have no other interest to disclose. Next slide, please. So I'm going to cover this broad array of topics just to give you a touch of understanding of what are the key issues that you should know about around substance misuse in older adults, what's the nature of the problem, and what are the unique issues that you should know about. I'm going to talk a little bit about best practices for screening and identification, and then finally discuss a little bit about brief motivational and other intervention strategies that are effective for older individuals. Next slide. So you've seen the headlines there. They have been in the news a lot over the last several years about the rising problems related to opioid problems, but also other substance use problems in older adults. They're real. We have good news in the last year with a 26% reduction in opioid overdose deaths, but there's still a lot of people dying unnecessarily from opioid, but especially from alcohol problems, much more prevalent, much more common deaths from alcohol-related issues than even from opioid issues, especially in older individuals. Next slide. And so what's driving a lot of this is that the baby boomers, as you all know, are aging. There are 73 million of us. They're born between 1946 and 1964, and they're now 61 to 79 years old. So this wave of individuals that are coming into later life have different risks than previous generations, especially around their exposure to substance use earlier in life, as well as their attitudes and values related to substance use and misuse. Next slide. The rapid increase has been unprecedented, with the older population growing very rapidly and outnumbering the younger population in the US. No other group has really had this kind of rapid increase. It's putting a lot of pressures. You've already heard, I'm sure, in the last few weeks of the pressures on Social Security and other retirement systems, on healthcare facilities and other services. Hugely problematic as we go forward, with the peak of the baby boomers just happening to reach 65 in this year or next year. So really, this is happening very quickly. It has a lot of implications for dealing with compulsive disorders like gambling and other drug and alcohol disorders, but also around thinking about prevention and early intervention strategies to try to avoid people from having serious problems. Next slide. So I want to talk a little bit about substance use and misuse and a little bit about how bad is this problem. Next slide. Well, this is a little busy slide, and I wanted you to point out a couple things. The first is the number one problem facing older individuals is not opioids. It's not, prescription drugs. It's alcohol. It has been alcohol for a long time. Until recently, the last 10 years, it was tobacco. Tobacco was the number one problem. And then cannabis is rapidly becoming more of a problem. We're seeing a lot more people having problems with cannabis. And then finally, opioids. The bottom line on this that I've circled in red really demonstrate the rates of problems in the population. 13% over the age of 65 have an alcohol use issue related to binge drinking or heavy drinking or even substance use disorder. That compares to about 12% for nicotine problems, including vaping, but also smoking cigarette products. Cannabis or marijuana is rapidly increasing, and we'll get to that a little more later. There's opioid at 2%. So overall, these are the rates that we know about in terms of over 65. But I wanted to point out the line just above that, which are the 60 to 64-year-olds. These are individuals that are the next wave of individuals coming into later life, and you can see the rates are much higher in this population. There's probably going to be some decrease as they get older, but I worry that we're going to have many, many more people in need of services because we haven't really done as good a job as we should in terms of education and prevention. Next slide. This is a slide focused on substance use disorder, those with the most serious problems. And as you can see, overall, for illicit drugs, about 1.5% of the overall population have a substance use disorder in later life, 65 and older. And alcohol is 5.1%. And then combining the two, it's 6.3%. And you see the numbers just above that, the 60 to 64 group have much higher rates of these problems. I want you to keep in mind that 6.3% of people with alcohol and drug serious problems, substance use disorder in the population. Because we're going to get back to that in the slide after the next one. Next slide. So it means that about 3.5 million people over age 65 are living with a substance use disorder, a very large number of people that continues to increase despite the decreases in opioid deaths and other things that are going on. We have a lot more increases of individuals because of the numbers of baby boomers that are aging. Next slide. So I just showed you about the number of people who have a substance use disorder. What about the people that are receiving treatment in the last year for that substance use disorder? And if you just go down to the bottom line and see on the left-hand corner, it's 0.4%. If you'll recall, it was 6.4% in the previous slide with the disorder, but only 0.4% actually receive any care for that disorder. So licensed counselors and therapists can play a major role in our ability to reach these individuals and provide needed services. I'd like to point out that if we had a slide that showed you the rates of people with breast cancer being a certain percentage, and that we only had a tiny proportion that actually got access to evidence-based treatments, we would be appalled. We should be appalled by this. The numbers are really, really not good, and we need to do a lot better in terms of our ability to reach these folks because they can really benefit from treatment and can benefit from counseling that could really make a difference in terms of the trajectories, morbidity and mortality, but also quality of life as they get older. Next slide. So what are some of the unique issues that older adults face? Well, the first has to do with normal age-related changes in absorption and metabolism. People absorb substances generally faster and metabolize them slower. So the negative impact of, for example, alcohol is longer. People have more exposure because they end up having faster absorption, slower metabolism. That's very simplified, but the idea is that as people get older, they're different in terms of their ability to metabolize substances. And as a result, can get into trouble really fast. With lower amounts than they've ever had previously, they get into more difficulty. They also have medical conditions, cognitive impairment, functional impairments, mental health and substance use conditions, other things going on. The interactions of these substances with those things can make things much worse for an older person, making it very unique in terms of the challenges that they may face. The frequent use of multiple medications for chronic medical conditions and for mental health and substance use conditions can really make people much more vulnerable. About 150 of commonly prescribed medications have warnings against the use of alcohol, for example. So these multiple medications can really make things much worse for individuals. The goals of care play a larger role in healthcare decisions. Older individuals want things in a different way, in a different package than younger individuals, and may really not respond as well as younger individuals might respond. And then finally, loss and grief are common and really need to be addressed in the context of substance use for older individuals. Next slide. Older folks with substance misuse are an invisible population. They misuse substances, but they remain hidden. And they remain hidden when providers believe that these problems are only for young people, that young people have substance use problems, not older people. They have negative thoughts and attitudes about aging. She's going to die anyway, so why should we deal with this? Well, we're all going to die anyway. And again, it has to do with quality of life. It has to do with wellness. They feel they don't have enough time for screening and assessment, or have a lack of knowledge about screening and assessment. I'm going to show you one question that can be asked that's been validated that can screen for alcohol problems. So if you can't ask one question, then I really wonder what we're doing. So those are all often reasons that people give of why folks remain hidden. He's an 83-year-old person who's been drinking his whole life. He never is going to change, so why bother? And I think we don't have that attitude about most everything else, whether it's diabetes or hypertension or other kinds of medical problems or even mental health problems. We have a unique view of this that I think is stigmatizing and problematic. Next slide. Um, Often symptoms are attributed to other things like dementia or cognitive decline. Well, he's just getting older and is forgetful. Well, it may be also related to their use of substances. Cognition can make it harder, though, to have people really remember what they're taking for prescription medications, but also to keep track of their alcohol and other substance use. And then finally, I've touched upon this already, our ageist and self-stigmatizing beliefs often prevent older individuals from getting care. And that's something that we really need to bust through and make sure that we are giving people opportunities to get the care that they need. Next slide. So what's the harm in a few drinks? You've probably seen reports about this, that the epidemiological data suggests that moderate drinking can be beneficial for cardiovascular health, maybe for neurocognitive health. That low to moderate daily drinking is most beneficial. And of course, the social aspects around the use of alcohol, which is really a social lubricant for many individuals, are all kind of positives that you may have seen in the media. But there's a lot of confounds to the data, and I'm going to get to really the biggest problem in a minute. But it includes things like sample selection, maybe just the well people, the fit elders with healthy lifestyles are reporting these benefits, and the data don't really get into that in the way that they probably should. Maybe that this is a surrogate for something else. Maybe those that are drinking are also have better nutrition and have better health behaviors like exercise. We don't have any gold standard clinical trials data. We can't randomize people to be in the drinking group versus the non-drinking group to be able to really know what's going on in terms of the potential health benefits. Next slide. Well, of course, if you talk about moderate drinking with being one drink of alcohol a day, I can live with that. It makes a difference of how you measure. It makes a difference with what we're talking about what a drink is. Next slide. So we have this concept of standard drinks And it basically means that different beverage alcohol has similar content of ethanol, the active ingredient, if you measure the amount that you're drinking. So 12 ounces of ordinary American beer, 5% alcohol beer, not the high-end Belgian specialty beers or the specialty brews that are much higher, can be 7, 8%. These are regular ordinary beer, has about 5% of alcohol. That's equivalent to 8 ounces of malt liquor. What's malt liquor? It's fortified beer. It's beer that's been fortified with distilled spirits. And that's about the same amount of alcohol as 5 ounces of wine. Most wine glasses are 10-ounce glasses, so that's about half a glass. If you fill your glass right to the tippy top, it is 2 drinks, not one. And that has about the same amount of alcohol as 1.5 ounces or one shot of distilled spirits, 80 proof distilled spirits. These are all equivalent in terms of the amount of alcohol or ethanol in them and are referred to as a standard drink. Many older people do not know this. They think that somehow beer and wine are different than distilled spirits because they're they think of them as soft beverages rather than hard liquor. They're actually the same. If you measure how much you're drinking, you have the same or relatively the same amount of alcohol that you're imbibing. So really educating people about this very simple concept can be very productive in terms of helping people prevent overuse. Next slide. So what do we recommend? This is the Centers for Disease Control and Prevention. For younger individuals, it's 2 drinks for men a day and no more than 1 drink a day for women. The rates are lower than that for older people. It's half it. So the recommendations is no more than 1 drink a day for older men and less than 1 drink a day for older women. So again, educating your clients, your patients about these limits can really help people contextualize what is recommended as a limit for how much people should be drinking. Next slide. And so binge drinking is a particularly problematic pattern of consumption. This is episodic, heavy drinking on a drinking day, drinking 4 or more drinks on a single occasion, drinking day for men, or 3 or more drinks on a day for women, older women. This is for older women and older men. Is considered a binge episode. These really increase risks for falls and for medication interactions and for ER use and many other things. It's 1 drink lower than younger individuals. So it's 5 or more drinks for a younger individual is considered a binge episode. So this is the absolute maximum that people should be drinking on any drinking day because it really imparts a lot more risk. Next slide. So I've said this already, and I'm going to skip through the first thing really quickly. Older adults are more vulnerable. So those age-related changes in absorption and metabolism means that you get higher alcohol content and you have more impairment on a given dose. Those dangerous interactions are really important to recognize and to make sure that people understand and that really making sure that when people are taking 7 medications, it's hard to know what all those interactions might look like going forward. And then the risk for a lot of other things, which includes confusion, can make it much worse, and impairment can get worse with alcohol as it interacts with these other things. Next slide. The risks are very narrow in terms of amount of consumption. Just 1 drink a day can make things much worse if you have gastritis, ulcers, other GI problems like liver and pancreas problems. It's really a very low threshold. 2 drinks, and it could increase risks for depression and gout and breast cancer for women, especially, but also for men. It has increases of insomnia and other sleep problems and memory problems, falls. It really just 2 drinks a day. You get to 3 drinks a day, and you have much higher risk for hypertension and stroke, diabetes, and other GI problems and other cancers. So it's a narrow range about what's a safe alcohol consumption level. Next slide. So I've already said that this is the recommended limits, but it's probably wrong. And we really are, the science is evolving as time goes on. And so what should we really recommend that people should limit their consumption about? And so the next slide shows you that there was a large study that was conducted of daily alcohol intake and risk of all-cause mortality. Over 500,000 people were included across many different studies that were reviewed in this important publication. Next slide. And what they found was across these, sorry, much more people, sorry, 4.8 million participants. Sorry, I was thinking of a different study, but 107 cohort studies. And what was found was there was a significantly increased risk of all-cause mortality among women who drank 25 or more drinks a day. That's 1.8 drinks, 25 or more grams per day. That's 1.8 drinks a day. And for men, it was 45 grams or 3.2 drinks a day. These are low levels that increase all-cause mortality. But most importantly, that idea that daily low or moderate alcohol consumption was not significantly associated with all-cause mortality, that we always thought, well, this is protective for cardiovascular or neurocognitive effects. In fact, there was an increased risk at these slightly higher levels of consumption. And so the recommendation is that we should advise our patients and our clients about what is the role of alcohol for them, and should they be drinking at all? And there are many countries like Canada, the UK, and others who have now come up with recommendations from their health agencies saying there's no safe consumption about alcohol. So we need to be a little more conservative than even what I've just shown you in terms of limiting consumption. Next slide. There's also the added complexity of co-occurring mental disorders when you think about alcohol and other problems, substance use problems. Older people are 3 times more likely to develop a mental disorder if they've had a lifetime diagnosis of an alcohol use disorder. And the common ones are major depression and anxiety, PTSD. 1.7 million Americans are living with a substance use and a mental health disorder. So these travel together. They co-occur and are comorbid with each other. And so if you have someone who has a major depression episode, you might want to know about their alcohol use as they get older, because that actually may be interacting with your ability to really treat their major depression disorder. That the same is true for PTSD and anxiety and other mental disorders. So I've always said if you have someone with a mental disorder that you are caring for, make sure you're also assessing for their use of alcohol and other substances, because they go hand in hand. Likewise, if you're dealing with someone who has a substance misuse problem, you want to make sure that you're also addressing their mental health conditions, because they are, again, interactive. Next slide. Cognitive impairment is really a major concern for older individuals. Alcohol misuse actually can increase the risk of dementia, and that older individuals are more likely than younger ones to experience harm related to the brain with heavy drinking, and really making sure that people understand that if they want to preserve their cognition, they want to really limit their alcohol use. No amount of alcohol is safe for older individuals. I've already said this, and we really should be paying attention to this and helping people understand these risks. I'm not saying that people should just stop drinking for the whole population, because some people enjoy it. It is a form of social interaction. It can also be a really positive thing in people's life, but really contextualizing it in all these negatives to make sure that people can really balance that. Next slide. And the next slide really talks about suicide. And these are risks for suicide. We often go right to other mental disorders like depression, which is certainly a major risk for suicide. But these other things are also very much connected to suicide, and substance use cannot be ignored in the context of suicide. Many people who have substance use disorders also are at high risk for suicide. older adults have the highest risk for suicide of the entire population, with those over age 85 having the very highest rates. And so making sure that we're paying attention to what's going on in terms of their substance use is really important. Next slide. The highest rates are for older white men who are depressed, who drink heavily, and who've recently lost their partner. People with an alcohol use disorder should be screened for psychiatric symptoms and for suicidality, and you need to treat the concerns about suicidality very seriously, because older individuals are more likely to complete suicide, more likely to use firearms as a means for suicide. So making sure that you're really doing all of the safety protocols that you need to do to make sure that people stay safe. Next slide. So having said all that, we have to really help our clients weigh the benefits and the risks of their use of substances. And I focused here on alcohol. I'm going to get to cannabis next, but really making sure that people have a better understanding of what's important to them and how do you balance those risks versus what kind of benefits do they experience. Next slide. So let's talk a little bit about cannabis use, a really emerging topic that I think is really relevant. Approximately, the number doesn't come to mind right now, 34, I believe, states and the District of Columbia have legalized cannabis either for medicinal cannabis or for recreational use. And about 22, I think, states have legalized it for both. So it's an emerging topic. There's more states, it seems like every year, that are legalizing cannabis. And if you live in Michigan, and if you lived in Ann Arbor, where I live, you can see the number of outlets for cannabis is truly astounding. There's more. Every corner seems to have it, just like banks and pharmacies. It's easier to order cannabis, or as easy to order cannabis remotely as it is pizza, and it can be delivered to your house. So it's very, very common. And I think that a lot of states have really experienced this. And it's something we should be aware of, that older adults, because of their experience as earlier, the so-called Woodstock generation, have had more experience with cannabis and are more likely to use cannabis as they get older. Next slide. So the legalization and availability is just right out there. There's been rapid changes from smoke product to very potent edibles and vaping. The THC content is much higher than it was in the 70s. So today's cannabis is not your grandparents' cannabis. It's used mainly for people to treat pain and to promote relaxation. So the medical use is mainly for pain indications, but for a lot of other conditions also. The past year, use in older adults is rapidly increasing, and the rates are expected to continue to rise. Certainly for medical reasons, but also for recreational reasons. Next slide. So, but there's a lot of risks, and the risks, unfortunately, are not really known, and we don't know how the risks might interact with prescription drugs. But we do know that use is associated with a lot of things that older adults do not want to have, which includes increasing injuries, impaired cognition, motor coordination. These are all risks for use of cannabis. And smoking cannabis carries many of the same cardiovascular health hazards as smoking tobacco. So we really need to be paying attention to this as a potential risk problem. Next slide. Next slide. Sorry, yeah, there's two of them. So there we've done a couple studies. We did one study, but we've done another one I don't show you here, around use of cannabis as an indication for behavioral symptoms of dementia, specifically agitation. If you search the internet, you'll see lots of anecdotal reports about how giving dementia patients edibles, gummies in particular, may be very helpful for managing their agitation and their other behavioral symptoms of dementia. There's not a lot of evidence about this. We don't know a lot about it, but we do know about the potential for negative consequences. So really making sure that your clients who may be having mild cognitive impairment or whatever think that cannabis might be a solution or be a problem. I'm sorry, a solution to a problem, or people coming in whose partner, whose spouse has dementia, and they feel like this is a way to manage that. There are other good behavioral techniques that this may not be the best first step that people should use. There are risks, as I showed you. Next slide. There's also acute cannabis intoxication where people take a gummy first thing in the morning because it helps smooth their mood, and then they forget that they've had a gummy, so they have another one, and they have another one, and all of a sudden they really have acute cannabis intoxication. It's a real thing. It creates psychosis and confusion and panic attacks that also increased blood pressure, all things we want to really avoid for older individuals. There's increasing risk, people coming into the emergency department with this acute cannabis intoxication. And so we need to be aware of that also. The edible market really sort of minimizes the risks, but in fact, there's a lot of risk potential. We don't know a lot of things. The regulations are really, I think, fairly loose. And so we don't really have a lot of knowledge and control over what we're getting. With alcohol, if you got a bottle of beer that's labeled 5% alcohol, that's what you're getting. But with all of these other products with cannabis, you don't really know from one time to the next whether it's the same product, the same THC concentration. And so it really is something that we should be careful about in making sure that these are not benign. They can be really dangerous for some people. Next slide. Okay, a little bit about identifying, screening, assessing for alcohol and drug misuse, and a little bit about gambling. Next slide. So I like to show this slide just to give you a conceptualization of what we typically deal with. We typically will focus on substance use on the top dimension and substance problems on the bottom, and we will usually focus on the tip of the triangle, those with heavy to severe problems, otherwise known as substance use disorder. What I would suggest to you today is that for older individuals, we should be broadening that perspective and include those who are at risk and problem drinkers or users, because those are the individuals that you can make a real difference in. You can make a difference with the most severe problems, but we shouldn't just go there as the only thing we're going to be treating, because a broader perspective will help prevent escalation of problems and potentially avert future problems. So really thinking of this more broadly than just those with substance use disorder, think about substance misuse as a key thing that you should know about, especially for older people. Next slide. So who should be doing this? Well, all providers have a responsibility, and the treatment improvement protocol that I'll give you the reference to at the end really recommends that everyone has a role. And you see mental health service and substance use treatment providers, those are really traditional mental health and substance use programs. But then a whole range of other people really should have some knowledge and understanding and ability to interact around this topic. So direct care workers, peer recovery support service providers, other kinds of caregivers, and really making sure that we're thinking that it's everyone's business to try to address this burgeoning problem that is really serious and really under recognized. Next slide. So what do we recommend for screening? Well, every person 60 and older should be screened for alcohol and other drug misuse as part of a regular physical examination, at least annually. Have a systematic review of all the medications. You want to screen and rescreen if certain symptoms are present, or if they have other life events like retirement or traffic accidents, activities of daily living issues. Uh, any major transitions really become a key trigger point for individuals, which includes bereavement. Death of a significant other can be a really major transition for many people. Ask direct questions about your concerns. You can preface it with a link to medical conditions or other health concerns or other mental health concerns. people skirt around this issue and feel embarrassed or really reluctant to ask these questions, you really need to get over that, because older adults will respond to you. And if you do it in a sensitive way, people will absolutely give you good information. Don't use stigmatizing terms like, I think you might be an alcoholic, or, we treat addicts. Those are stigmatizing terms. Older people, especially, are attuned to those things. Each practice setting should have a plan. So when you screen someone positive, you actually should do something about it. Next slide. So what do you screen for? Well, for drinking, a single item. How many times in the past year have you had 5 or more drinks in a drinking day? 4 for older individuals, actually. Um, and if it's more than once, then you can do other screening. It's a really good one item screen that would allow you to have a really easy cut. Then there's a variety of other questions that you can ask. It's 3 items from the audit, which is the alcohol consumption quantity and frequency and binge drinking questions, which is really great. The audit C, the consumption questions. There's a lot of alcohol consequences instruments. We developed the Michigan Alcohol Screening Test geriatric version, and both a full version and the short version, 20 items and 10 items. Good to get very broad understanding of consequences. Next slide. There are a lot of other instruments that are available. I'll point you to the right direction of where you can get these. They're all available in the treatment improvement protocol that I'll show you at the end. And they're all really good as a first step for identifying individuals in a variety of settings. Next slide. So when I think about the spectrum of interventions for older individuals, we really want to have in our toolkit many different things that we can offer based on what kinds of levels of consumption and problems that people have. I'm going to focus today a little bit more on brief interventions, but there are prevention and brief advice, pre-treatment interventions, and also formal specialized treatments, all important as we think about this. But brief interventions is kind of a modal thing that can get reimbursed for Medicare and can be very powerful in changing the course for individuals. Next slide. So it's called SBIRT. You may have heard about this. Most states have rolled it out in a variety of settings, mainly emergency departments, but also many other settings. We did the foundational work as well as others in this topic. It's screening, brief intervention, and referral to treatment. Next slide. It is a universal screening of patients within mainly health settings, medical settings, using validated screening tools. And so the screening part is use validated screening tools and screen everyone, because you can't really pick out those that are positive from just talking to them. You really need to ask them the specific questions. If they screen positive, then providing a brief intervention with a guided discussion with a professional is the next step. And if it reveals a use disorder, having a warm handoff and referral to specialty substance use providers is really important. Not just giving them a piece of paper, you need to go talk to someone, but really helping them make the connection to a treatment provider. So that's simple. It's screening, it's brief intervention, and referral to treatment. Very effective. Next slide. So it takes advantage of the teachable moment. The people are there seeking care for other things usually, and so you can teach people a little more than they may be more receptive to getting health advice and addressing concerns that they may have. They often are not seeking substance use treatment, but screening opens the door for awareness and education, and it focuses on that low to moderate risk use as a prevention before full addiction occurs. Next slide. And so I'd like to point out that substance use disorder treatment for older individuals actually is not needed, or that older people don't self-refer, that they're less likely to seek treatment unless they have a nudge. And the nudge is often through our criminal justice system. Unfortunately, they get a impaired driving offense. But we should be doing more nudging with our medical and other health care providers so that we really can help people self-refer. But I really wanted to make the point that education and brief interventions are often enough to help people prevent, reduce, stop drug use and prescription medication misuse, that we really can do sort of a lighter touch intervention that can be very powerful and doesn't have to be a full-blown substance use disorder treatment facility. There's lots of ways that are reasons for people to go to those facilities with severe problems because they really are life-saving, but not everyone needs them. Um, Most people don't need specialty treatment. They need programs and providers that can be understanding what their unique concerns are and that can help them address these issues. Next slide. So the key components are there. You can read about them and know about them. They're really straightforward. They are conducted over a course of 15, 20 minutes, and it's done using a workbook. Next slide. Um, and it really addresses a lot of things that older adults have in terms of their treatment barriers, like a resistance to help, asking for help, those disdainful labels, often lack of transportation so you can do it remotely. There's no significant others that helps motivate them to change, and there's no employers often because they're retired to help motivate them to seek help. Providers are less likely to refer, as I've already said. And then we have these gaps in substance abuse, aging, and mental health services siloed programs that really need to be talking to each other and really integrated in a much more comprehensive way. We're almost done. Next slide. And so I'm not going to spend much time here, but in terms of treating substance use disorders, um, really making sure that screening is done across all kinds of settings, tailoring the content in terms of screening and assessment tools as well as treatment options to older individuals, making sure those tailored treatment choices addresses their unique needs, using a stepped care approach to the management of referrals, and then finally making sure that treatments are age specific and age sensitive, that we're not just throwing older individuals into a mixed age young person's group with the pace that's too fast for them and not appropriate in terms of their own unique concerns. Next slide. And so I'm going to skip this, but these are many different things that you can do. Next thing. So the takeaways today is that the rates are increasing and vary widely, that substance use is under-recognized and undertreated, that we have older people are different than younger individuals and smaller amounts have bigger impact. And then finally, treatment works. So these interventions have been shown to be very effective for older individuals and help with dealing with their unique needs. Next slide. There's lots of resources out there. You can look at them here. I recommend them all. I would really encourage you. NIAAA, the National Institute on Alcohol Abuse and Alcoholism, has a treatment locator service, or SAMHSA has that, I guess. SAMHSA has it, but NIAAA has a lot of things. SAMHSA has lots of great resources. I recommend that you go there. Next slide. And last slide, which is really this treatment guide is something that I chaired the national panel way back in 1998, and then we did a complete revision of it in 2020. This is available for free online at samhsa.gov. It is the latest evidence-based guidance on how to identify, manage, and prevent substance misuse in older people. There's a provider focus on this, but there's also other stakeholder chapters in it that are focused on individuals and families. And so making sure that you can also refer your clients to specific areas or print out sections that might be helpful to them. This is a comprehensive guide. All the screening instruments I talked about today are included in it, and I think it can be very effective for you to learn more and to be able to address this complicated issue that I think is really important, that you have a really opportunity to make a difference in people's lives. And with that, I'm going to stop. And thank you very much for being here today. Oh, here's the E4 Center. There's lots of resources on the E4 Center website, which I recommend that you go to. There's many videos and other resources for you to be able to get more expertise, not only in substance use issues, but also older adult issues. Jolie?
Thank you. Thank you so much, Dr. Blue. We really appreciate it. There's your contact information as well for people that may want to get in contact with you. And then I'm going to ask to go to the next slide here. And I'm going to ask our panelist. I'm going to start with Dr. Northey and let him take a few minutes to talk about MFTs and also about the presentation, maybe 3 or 4 minutes. And then Dr. Northey, if you'll hand it off to Dr. Clarke after that, and then we'll take some questions if we have some time for those. Thank you.
Sounds good. Thank you very much, Fred. Great presentation. A lot to digest there in a short amount of time. And so given 3 to 4 minutes, I'm going to do the best I can. And I'm going to start out with a story that sort of it goes back 25 years ago when I was sitting at a table at the National Institute of Alcohol Abuse and Alcoholism, NIAAA, with Dr. Enoch Gordis, who was the director at the time. And he was talking about all these great things that were on the internet and the website for NIAAA. And I was a newly hired professional development research specialist for the American Association for Marriage and Family Therapy. And I knew a couple of things. One, we had done some research with Samson money to find out that about 85% of MFTs were seeing clients that had a substance use disorder, either primary or secondary. And also that MFTs at the time were a little technophobic, and getting them to the NIAAA website was going to be a challenge. So I just pointed those things out, thinking nothing of it. And then later on, some of his staff came by and said, made some good points. How can we get marriage and family therapists more aware of alcohol abuse and do better with screening, the SBIRT type of stuff, and assessment of people who are suffering with alcohol use disorder? So we ended up creating a booklet that went out to all MFTs back around 2003, 2004, called Alcohol Problems in Intimate Relationships. And I think a lot of that stuff that was in that brochure and that booklet is still applicable today. And we have not done a great job, I think, of keeping that up. I'm a practicing therapist. I do have clients that come in, but most of the time they don't come in for a substance use disorder or alcohol use disorder. They come in because they're having quote unquote communication problems, which anybody who's an MFT knows that everybody comes for communication problems. But then it finds out that the communication problems about coming home drunk on Friday night and having issues around that. And that is what is contributing to the overall problems. So I do think that screening at the outset is very important to make sure that that substance use is not impacting the relationship or being, sort of a co-occurring issue relative to couples and families. Fred also talked about the treatment and improvement protocol for substance use in older adults. There's also one, I think it's number 39, which is for family therapy and substance use disorder. For those of you that may be more focused on the substance use side, want to learn more about the family therapy side and integrating that. And I do, as I guess with older populations, right, that usually the next generation, the children of the baby boomers, right, that they are probably people that are resources and realize what's going on in these particular situations. And so tapping into those folks, if you're getting clients that are older, that they, children and other support folks should be included in that. And I could talk for another 20 minutes, but I know I can't. So I'm going to turn it over to Dr. Clarke.
Thank you both. Dr. Blow, the presentation was fantastic. I always think of the opposite. It used to be just say no, N-O. And I think now we're all about just say no, K-N-O-W. So I'm just going to add a few things. An exercise I'd encourage all the listeners to engage in after the webinar, maybe not during, but it's to do a 60-second free write. So take your cell phone and set a stopwatch for 1 minute and write down the first thoughts, feelings, images that show up for you when you hear the words addicted older adult. And I say that to encourage you to really begin, as Dr. Blow articulated, deconstructing biases, assumptions, and stereotypes that you might hold related to older adults, aging, substance use. Two other reflective questions that might be helpful in your journey, kind of how is substance use in older adults viewed in your culture, your family, your community? How, if at all, have you maybe been biased by your own age, by your own personal experiences with aging and older adulthood. The tip series that Dr. Blow and colleagues put together, again, I just want to underscore, he underscored it. It's that good that I will underscore it again. On page 97, speaking of bias, there's a wonderful chart that Dr. Blow and colleagues put together regarding ensuring age-sensitive diagnosis. And on that chart, they go through each of the 11 substance use disorder criteria and identify specific criteria that may be vulnerable to bias. And so that's a great resource in your, for your diagnostic tool belt. So for example, one of the diagnostic criterion that we all know from substance use disorders is recurrent use resulting in a failure to fulfill major role obligations. Well, if your client population has traditionally been younger adults or middle-aged adults, those role obligations may look different with older adults versus they're in some ways overlap, but they in some ways may be different. So the chart on page 97 identifies some great diagnostic considerations so you can avoid bias and get an accurate diagnosis with your older adult clients. A couple more things. I love Dr. Blow's scale image of looking at the benefits and costs. And we know clinically through SBIRT and other things, one of the things we're targeting is developing intrinsic motivation to change. So I think it's also important with that to get extremely developmental. So think about the age and stage that folks 60, 65 plus might be in. If we go Erickson psychosocial stages, we're thinking of integrity versus despair. So folks may be in process of life review, taking stock, being reflective. And so Dr. Blow talked about looking at what's important to you. So with your clients, values work can be very helpful because your clients are in the middle of that process. So helping them identify what have they stood for? What's been your personal compass for a fulfilling life? But then we bring in the substance use through the side door. How does your drinking fit with your value of autonomy? How does your cannabis use fit with your value of beauty or responsibility? So kind of helping clients identify and codify their values and then bring in like the fit question. How does your substance use fit? Also, folks 60 and plus, they have accrued a lifetime of strengths and wisdom. And so an advice type question can be really helpful here to get into this motivation for change. So once you get to know their situation and maybe concerns around their substance use, asking, what advice might you offer to a close friend who was going through XYZ? And that XYZ would be what your client is going through. So maybe they've, their doctor's given, said, your liver enzymes are high, XYZ. And so, you've shared a lot of, and I've observed a lot of strengths and wisdom with you. So I wonder if you had to impart that wisdom to a close friend and their physician said your liver enzymes are high, and there's some concerns about, maybe some, high episodes of drinking, what might you impart to that close friend? And then how can you apply your own advice to your own life? And then lastly, Dr. Blow's, the tip manual also talks about wellness. And so we know that substance use is just but one part of the picture of a whole life. And so I'm strongly in favor with older adult clients or any clients is bring a wellness model into the session. Have your clients self-assess their stronger areas of wellness, their growth edges, and then bring in substance use through the side door again. So I wonder, let's go through each of these dimensions of wellness. I wonder if you could talk about ways in which your drinking enhances this dimension and go through each dimension, and then now flip and go through the other side of the coin. I wonder how, if at all, your drinking maybe detracts or takes away somewhat from your wellness in this dimension. And so it's a great side door technique to bring in substance use and ensure that you're looking at the whole picture because substance use is just one part of the client's life. Again, Dr. Blow's manual, the tip manual, SAMHSA also has an 8-dimension model. You can just Google SAMHSA 8 dimensions of wellness. They have a great wellness model. The National Wellness Institute, as well as, Jane Myers and Tom Sweeney have the Wheel of Wellness. So all that to say is there's lots of different wellness models you might incorporate with your older adult clients related to substance use. Again, this has been an absolute pleasure. Thank you.
Thank you, Dr. Blow, Dr. Northey. Dr. Clarke, to all of you for sharing your time, your expertise with us today. Very thought-provoking. My wheels are certainly turning. This information on how clinicians can provide vital healthcare services to Medicare clients in the areas of substance use and substance misuse has been tremendous. I certainly learned some new things, and I'm thinking back to some stories I could share too, but we don't have time for those. You all covered so much ground. Unfortunately, we're not going to have time for questions. We did have a few questions that have come in, and so what I'm going to do is get with our esteemed speakers after the presentation here and get some responses to those questions, and we will email those out to our attendees if our speakers are willing to do that. Hopefully they will be willing to. I think they will be. They're all very passionate, obviously, about what they do. So thank you very much. The Medicare Mental Health Workforce Coalition and NBCC would like to thank all of you for spending your valuable time with us today, our speakers and our webinar participants. We have also provided a few slides with Medicare resources. Yes, you'll see some of those, including how to enroll in Medicare. If you are still interested in doing that, or if you have not done that just yet, we're giving you some information on how to do that there. The link to the session evaluation is posted in the chat, and we're also going to email that to you following the meeting. So in a few minutes, it'll take a few minutes for us to get that out to you, but be on the lookout for an email. To receive continuing education credit, you do have to complete the evaluation, including the attendance attestation, which is part of that evaluation, by July 24th at 5 p.m. Eastern Time, and certificates are going to be emailed by July 31st. We are only providing credit for the live attendance of this webinar. We certainly hope you found this session informative. I know I did, and we look forward to seeing you again as we continue our Medicare webinar series. Thank you, and everyone have a wonderful rest of your day.